Hello everyone, now let us discuss about the pharmacology of drugs for gout. Now let us discuss about gout. Gout is a metabolic disorder characterized by hyperuricemia. The normal plasma urate concentrations are 1 to 4 mg. When the blood levels are high, it precipitates and deposits in the joints, kidneys and subcutaneous tissue. In addition to that, the secondary hyperuricemia may occur in leukemias, lymphomas and polycythemia, especially when treated with chemotherapy or radiation due to enhanced nucleic acid metabolism and uric acid production. And also, in certain cases, it is drug-induced due to thiazides such as furosemide and also pyrazinamide, ethambutol, levodopa, clofipgrate. They reduce the uric acid excretion by kidneys. This leads to hyperuricemia. The drugs are categorized based upon the chronicity of the gout. For acute gout, the majorly used drugs are NSAIDs, colchicine and corticosteroids. And for chronic gout or hyperuricemia, the drugs used are of two types, uricosurics and synthesis inhibitors, uric acid synthesis inhibitors. Examples of uricosurics are propenicid and sulfenpyrazone, whereas synthesis inhibitor is allopurinol. Now, first of all, coming to NSAIDs, one of the strong anti-inflammatory drugs, for example, indomethacin, naproxen, piroxicam, diclofenac, and etoricoxib, is given in relatively high and quickly repeated doses. Majority of the patients, they prefer NSAIDs over colchicine because of their strong anti-inflammatory action, not the uricosuric action. Naproxen and piroxicam specifically inhibit chemotaxic migration of leukocytes in the inflamed joint. Now coming to colchicine, it is an alkaloid from Colchium autumnale. Usually, let us first discuss the etiology of acute attack of gout. An acute attack of gout is started by the precipitation of urate crystals in the synovial fluid, and they start an inflammatory response. Chemotactic factors are produced and granulocyte migration into the joint occurs, and they phagocytize the urate crystals and release a glycoprotein which aggravates the inflammation by, first point is increasing the lactic acid production from the inflammatory cells. This leads to reduction in the local pH so that more urate crystals are precipitated in the affected joint. And the second mechanism is releasing the lysosomal enzymes which cause the joint destruction. Inflammation is aggravated by increasing the lactic acid production from the inflammatory cells, which leads to reduction in the local pH so that more urate crystals are precipitated in the affected joint. And secondly, by releasing the lysosomal enzymes which cause joint destruction. Colchicine does not affect phagocytosis of urate crystals, but it inhibits the release of glycoprotein and the subsequent events. And by binding to fibrillar protein tubulin, it inhibits the granulocyte migration into the inflamed joint and thus interrupts the vicious cycle. Other actions of colchicine are antimitotic. It causes metaphase arrest by binding to microtubules of mitotic spindle. It was tried for cancer therapy but abandoned due to toxicity. It is used to produce polypodly in plants. It also increases the gut motility through neuronal mechanisms. The other actions are antimitotic and increasing the gut motility. Coming to the pharmacokinetics, colchicine is rapidly absorbed orally, partly metabolized in the liver and excreted in bile, and it undergoes enterohepatic circulation. Ultimate disposal occurs in urine and phases over many days. It is well absorbed orally and partly metabolized in liver. One important point is inhibitors of CYP3A4 retard colchicine metabolism and enhance its toxicity. and usually the toxicity is high and dose related. This usual symptoms are nausea, vomiting, watery or bloody diarrhea and abdominal cramps. They occur as dose limiting adverse effects. And in overdose, colchicine produces kidney damage, CNS depression, intestinal bleeding, death due to muscular paralysis and respiratory failure. Coming to the uses, colchicine is the fastest acting drug to control an acute attack of gout, and it is a second line of drug to NSAIDs. The next category are corticosteroids. Intra-articular injection of a soluble steroid, for example, triaminocolone acetonide, 10 mg in small finger or toe joints, whereas 30 mg in wrist. They suppress the symptoms of acute gout. Crystalline preparation should not be used for this purpose, and it is indicated when one or only few joints are involved and in those not tolerating NSAIDs and colchicine. Corticosteroids should be given in those patients who are not tolerating NSAIDs and colchicine. Systemic steroids are highly effective and produce nearly a rapid response as colchicine, but are reserved for patients with renal failure or history of peptic ulcer bleed, in whom NSAIDs are contraindicated, or for cases not responding to or not tolerating NSAIDs. Prednisolone 40 to 60 mg may be given once a day, followed by tapering doses over 1 to 2 weeks. Coming to chronic gout, when pain and stiffness persist in a joint between attacks, it is indicated that gout has become chronic. Other cardinal features are hyperuricemia, tophi. Tophi are nothing but chalk-like stones under the skin in pinna, eyelids, nose, around the joints and other spaces, and urate stones in the kidney. And chronic gouty arthritis may cause progressive disability and permanent deformities. Coming to uricosurics, the first drug is probenecid. It is a highly lipid-soluble organic acid. It competitively blocks active transport of organic acid by OTP at all sites, especially in case of renal tubules. And this transport is bidirectional. Uric acid is largely reabsorbed by active transport, while less of it is secreted. Only 1/10 of its filtered load is excreted in the urine. Uric acid is largely reabsorbed by the active transport and only 1/10 of the filtered load is excreted in urine. The major transporter involved is URAT1, which is a member of OATP family, and the probenecid therefore inhibits the reabsorption and promotes the excretion of uric acid and lowers its blood levels. Probenecid inhibits the active reabsorption by active transport and promotes the excretion of uric acid, lowering its blood level. It does not have any other significant pharmacological action, and it is neither an analgesic nor anti-inflammatory. Coming to interactions, probenecid inhibits the urinary excretion of penicillins, cephalosporins, sulfonamides, methotrexate and indomethacin. It inhibits the biliary excretion of rifampicin, pyrazinamide and ethambutol may interfere with uricosuric action of probenecid. Probenecid inhibits the tubular secretion of nitrofurantoin. Next point is aspirin blocks the uricosuric action of probenecid. So here pyrazinamide, ethambutol, they interfere with the uricosuric action of probenecid, whereas aspirin blocks the uricosuric action of probenecid. Coming to the pharmacokinetics, it is completely absorbed orally. It is 90% plasma protein bound, partly conjugated in the liver and excreted by kidney. Its T-half is 8 to 10 hours. Coming to adverse effects, dyspepsia is the most common side effect of probenecid. It occurs in up to 25% patients with high doses. It should be used cautiously in peptic ulcer patients. It should be used cautiously in peptic ulcer patients. Rashes and other hypersensitivity phenomena are rare. Coming to the uses, probenecid is a second line or adjuvant drug to allopurinol. Colchicine or NSAID cover is advised during the initial 1-2 months to avoid precipitation of acute gout. It is ineffective in the presence of renal insufficiency, and it is also used to prolong the penicillin and ampicillin action by enhancing and sustaining their blood levels, especially in case of gonorrhea and SAB. Next, probenecid is given along with cidofovir. This is an important point. Probenecid is given along with cidofovir, a drug for CMV retinitis in AIDS patients to prevent its nephrotoxicity. Now coming to the next drug, it is sulfenpyrazone. It is a pyrazolone derivative related to phenylbutazone, having uricosuric action but is neither analgesic nor anti-inflammatory. It inhibits the tubular reabsorption of uric acid. Though equally efficacious as probenecid, sulfenpyrazone has gone into disuse because of the more gastric irritation and other side effects. And it also inhibits the platelet aggregation. The next drug is lesinurad. It is a new uricosuric drug approved recently by US FDA as a treatment option for hyperuricemia, either alone or in combination with xanthine oxidase inhibitor, and its mechanism of action is similar to that of probenecid. Coming to next class, uric acid synthesis inhibitors. The drug is allopurinol. This hypoxanthine analog is a purine antimetabolite. It is a competitive inhibitor of xanthine oxidase. Allopurinol is a competitive inhibitor of xanthine oxidase, the enzyme which is responsible for uric acid synthesis. Allopurinol itself has shorter T-half, that is T-half is 2 hours. But its major metabolite alloxanthine, which is oxypurin, it has long T-half up to 24 hours. And it is a non-competitive inhibitor. And this alloxanthine is primarily responsible for uric acid inhibition in vivo. And because of the raised levels of xanthine and hypoxanthine, because of allopurinol, some feedback inhibition of de novo purine synthesis and reutilization of metabolically derived purines also occurs. Pharmacology is well absorbed orally, not bound to plasma proteins, and is metabolized largely to alloxanthine. Coming to interactions, allopurinol inhibits the degradation of 6-mercaptopurine and azothioprine, and their doses should be reduced to 1/3. Probenecid shortens the T-halves of alloxanthine, whereas allopurinol prolongs the T-half of probenecid. And alloxanthine can potentiate warfarin and theophylline by inhibiting their metabolism. A higher incidence of skin rashes has been reported when ampicillin is given to the patients who are on allopurinol. Coming to adverse effects, hypersensitivity reaction consisting of rashes, fever, malaise and muscle pain is most common. Renal impairment increases the incidence of rashes and other reactions to allopurinol. Stevens-Johnson syndrome is rare but a serious risk. Gastric irritation, headache, nausea and dizziness are infrequent. And liver damage is generally rare. Coming to contraindications, it is contraindicated in hypersensitive patients during pregnancy and also lactation, and cautiously used in elderly, children and in kidney or liver disease. Coming to uses, it is a first choice of drug for chronic gout, and with long-term allopurinol therapy, tophi gradually disappear and nephropathy is also halted or even reversed. In addition to gout, allopurinol is used to treat secondary hyperuricemia due to cancer chemotherapy, radiation or thiazides or other drugs. It also used to potentiate 6-mercaptopurine and azathioprine in calcium chemotherapy and immunosuppressant therapy. Coming to next drug, that is febuxostat. It is a newer non-purine xanthine oxidase inhibitor, equally or more effective than allopurinol in lowering the blood uric acid levels in patients with hyperuricemia and gout. It is rapidly absorbed orally and highly plasma protein bound, oxidized as well as gluconate, glucourinate conjugated in the liver and is excreted by kidney. And plasma T half is 6 hours. Coming to adverse effects, the hypersensitivity reactions are rare with Fleblusat, but it should be stopped if they occur. And the most important adverse effect is liver damage. Liver function need to be monitored during the Flebuxosat therapy. Diarrhea, nausea and headache are usual side effects. And by inhibiting the xanthine oxidase, Flebuxosat has the potential to interact with mercaptopurine, azathioprine and theophylline. And it should not be given with to the patients who are receiving these drugs. It is an alternative drug to allopurinol but should not be combined with it. However, the two can be given sequentially in case of intolerance and non-responsiveness to one. They should not be combined, but they can be given one after the other. It is not indicated in malignancy associated hyperuricemia, and like other drugs used to treat hyperuricemia, whenever Flebuxosat therapy is initiated, for the first 1-2 months, NSAIDs and colchicine cover should be provided. Next drug is pegloticase. It is recombinant uricase, an enzyme which oxidizes uric acid to highly soluble allantoin that is easily excreted by kidney. Humans usually lack this enzyme, and in this preparation the enzyme has been coupled with methoxypolyethylene glycol (MPEG), which serves to prolong its journey in the body, permitting IV infusion of the drug to be given every 2 weeks. It is indicated only in rare cases of refractory sympathetic gout, and pegloticase is immunogenic and carries higher risk of infusion reactions, including the anaphylaxis. And it should be administered only by professionals in setting where facilities for managing anaphylaxis are available. Due to formation of antibodies, response is gradually lost in many patients. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.